For giving me the opportunity to take part in this important webinar. And with that background given by Dr. Prashant, I will take the story forward, giving you the basics of the pharmacokinetics and pharmacodynamics and the lab-based principles which one should understand in proper selection of the antibiotic to treat our ocular infections. So I'm going to cover the basic aspects linking the lab information with the clinical approach. So this is a situation that we encounter very commonly. We see all sorts of infections, and who are the people who are going to prescribe and who will benefit from this webinar? They are the ophthalmologists. What are we talking about? So which antimicrobial agent should we choose? And as Prashant has nicely said, it's very important to be aware of what is the global perspective, what is the entire armamentarium available to us, combined with your local information. And finally, it is your particular patient, how that patient has presented, what the patient has been through, what treatment has already been prescribed. So always take that time to look carefully at the past records and particularly inquire into the history and the response the patient has had to whatever medication has been given, because that can give you a clue in the current scenario where you may encounter patients, as Prashant had shown, where they've already taken multiple antibiotics and they are not responding. Now, why we choose a particular agent? As I said, there is a rationale, which is a basic background theoretical information combined with the clinical, particular clinical patient or the clinical scenario that one encounters. And then how is it to be administered? So that is another thing that we need to consider. Is it going to be topical? Is it going to be by local injection, as is the case required for, say, endophthalmitis, where you have to give it intravitreally, or even sometimes intracameral injections for severe corneal ulcers and so on, and systemic. So these are all the things that the ophthalmologist has to take into concern. Basically, the goal is to eradicate the pathogens effectively with minimum toxicity and avoid selective buildup of resistant bugs. We do understand the concept of survival of the fittest, and microorganisms are no different from the rest of us. So when they are invading a particular eye or an ocular tissue, and they are now being attacked by the antimicrobial agents, the ones which are stronger, they are going to survive and then multiply, having the full playing field to themselves when the others are all knocked out. So therefore, whatever agent you give has to be effective and successful in eliminating all the organisms at one go as far as possible. So that is something which is important. And obviously, the level of seriousness will depend upon the level of involvement. Corneal ulcers are a very serious condition, similarly endophthalmitis. Whereas if you have a case of bacterial conjunctivitis, say a mild bacterial conjunctivitis, that is not the case to overload with a whole lot of our, most effective antibiotics. So you have to be very judicious to know what is the condition you're treating and how you're going to approach. So as I said, important considerations also, it's not just the antibiotic which is working, it is also the host defense mechanism. There is the inherent immunity of the host, which may be compromised in conditions where the person may be diabetic, particularly uncontrolled diabetes mellitus. There may be autoimmune disorders. The patient may be immunosuppressed or on chemotherapy for systemic malignancies. Similarly, there may be local ocular pathologies such as dry eye, and they may have already been on steroids for some other reason, or there may have been misuse of steroids. So all the host defense mechanisms also you have to take into consideration and not expect that your antibiotic is going to work on its own. Of course, as I mentioned, the infected site will be taken into consideration. Then the virulence of the pathogen. One impression that you will get about the virulence of the pathogen is going to be on the clinical course. So the usual standard workup and the way the infection is progressing, whether very rapidly deteriorating, the relentless progression of the lesion, etc., will help to give you a clue about the virulence. And then the antimicrobial agent is what you are going to provide to get rid of the infective organism. You have to be aware of the pharmacological properties of the antibiotic that you're going to choose, its mode of action, and its microbiological effects. Mode of action is important because if you're using combination therapy, you must make sure that the two are going to work supporting each other, and not one is going to block the effect of the other. So it's very important to have a basic knowledge about the mode of action as well. Now, generally, if you see, largely over the years, most people are cognizant of the fact that if you have corneal ulcers, a corneal scraping is a very important, practical, so almost essential tool we would consider as corneal specialists. So generally speaking, if you do a corneal smear, you straight away will get some idea about which direction to take, whether you identify gram-positive cocci, gram-negative, or you see a fungal organism. So that gives you a clue straight away. So here again, we emphasize as corneal specialists that a corneal scraping should be done. So, I know Sujata is going to cover it later on. And once you get information or a clue about the organism on the basis of your corneal scraping, the tendency or the preferred practice is to give a targeted antibiotic based on what you think is going to work most. So that is your empirical treatment. And then you will wait for the culture report and the clinical response to reassess or reevaluate after about 48 hours to decide, now do you continue or do you change? So there are a whole host of literature available, different organisms and different antibiotic spectrum. And as you have understood by now, this is going to vary from place to place, country to country, and situation to situation. So largely you need to know, is it bacterial, fungal, viral, or parasitic? If it is bacterial, is it seeming to be gram-positive and gram-negative? And here again, despite your best clinical judgment, I would suggest that you should rely on a smear to give you a more definitive direction. And then correspondingly, you would choose the antibiotic, because as is very clear, the antibiotics are not uniformly effective against all organisms, even though they have broad spectrum coverage. So the properties to look for when choosing would, of course, be that you would choose an agent. Once you have a clue as to what is the organism you're dealing with, then you would like to choose the agent which has a stronger efficacy against that particular bug. It should be broad spectrum, because you cannot be 100% confident that that is the exact agent. So therefore, there may be simultaneous infection which may be latent. So you would like it to be effective against both gram-positive and gram-negative when you're choosing empirical therapy. And it has to have a very fast action. It should have a good safety profile. And this is something that we are now becoming more aware of, that also one has to pay attention to the possibility of the organism itself leading to greater resistance. So therefore, you would like to select antibiotics which have a low propensity to induce resistance in the bacteria or the microorganisms. So largely, fourth-generation fluoroquinolones were certainly a great improvement in the nature of agents that we had. We knew that they had broad spectrum against largely both gram-positive and gram-negative organisms. And when they first came, there was the very exciting idea that here we have an agent which is less prone to resistance. Of course, time has shown that this is not entirely true, and there is an emerging resistance. And the other nice thing about the introduction was that they were preservative-free, particularly moxifloxacin. So this made it very attractive, and it still remains a very attractive aspect of moxifloxacin, that it is preservative-free. So generally, the shifting trends in bacterial keratitis in South Florida and emerging resistance to fluoroquinolones is just one of the papers we started emerging in 2000, showing that actually there are organisms which are developing resistance to these so-called suspected or expected to be magical drugs. Now, talking about fortified combination therapy versus monotherapy, here this is again a very still kind of a debatable point. The benefit of fortified combination therapy was that you are using two agents, that they are freshly prepared, and you're using them at very high concentration with the idea of getting rid of all the organisms straight away. But there are disadvantages. There is a high cost. And the other thing is there is a contamination risk. So this has to be prepared. And not everybody has access to a pharmacy which will prepare and dispense it. So largely many ophthalmologists will just have to prepare it themselves. And it is compounded and they have a short shelf life, which again is a disadvantage because it's not very convenient often for the patient to come back every 4 to 5 days to get a fresh bottle of the medications. And sometimes they may just run out of it and they may not be able to come back in case there's some exigent circumstance, and then they won't have anything to use. So this is something which happens in countries where there are long distances that the patient has to travel and so on. So definitely, if you have a commercially available product which is prepared in a good manufacturing practice lab, properly bottled, labeled, etc., that certainly is a big advantage. Cost effective in the long run because compared to the cost of purchasing the injection and providing it and the multiple times it has to be prepared, that can make a difference. The low risk of contamination is as expected because it's a commercially prepared dispensed product, and it is commercially available, it has a better shelf life, and they do not require then refrigeration. So largely, the general trend is that based on your clinical judgment and your smear report or purely on a clinical judgment, most ophthalmologists, even corneal specialists, will start on empirical therapy. However, whether it is going to be fluoroquinolone monotherapy or fortified antibiotics depends largely on the nature of your clinical practice and what is your experience. And this is the importance of knowing what is the general profile of organisms in your region. So it seems very skeptical that monotherapy could work when you're so used to using a combination drug, but it is very important because of all the reasons cited before to gather evidence in a systematic randomized controlled trial, whether what we think and what we feel is actually translates into actual practice. So we did find that it is indeed true that monotherapy works because the importance was to find out the scenarios where monotherapy should be recommended. However, in the course of our clinical experience, so one is that you have a randomized control trial where you have selection criteria and everything is done in a perfect way. But at the same time, we have patients walking into the clinic who have already been on treatment before. So we also looked at our data, a retrospective analysis of patients who were not in the trial, and we found that largely the in vitro susceptibility of bacterial keratitis isolates to 4th-generation fluoroquinolones was reasonably good in 2010. However, even then, we did found there was an emerging resistance of Pseudomonas to both moxifloxacin and gatifloxacin. Now, in as late as 2020, we have another publication on the value of fortified aminoglycosides, cephalosporin and tobramycin as first-line treatment and in fluoroquinolone-resistant bacterial keratitis. And you will find that often you will have a cycle. Just as in the fashion world, you will have a cycle in the kind of clothes people wear, and after 10 years, the old fashion will come back. So similarly, in this way also, you'll find that there will be cycle. There'll be emerging resistance, and after a period of 10 to 15 years, you'll find that the organisms are now sensitive to the agents which were not used for several years. So this is again highlighting that a lot depends upon what is the prevalent rate of infection, what is the prevalent susceptibility, and or the bacteria, the antibiotics which have not been used for some time, the bacteria do not have a memory and they forget that whatever mechanisms they had to be resistant to them, and they can be effective again. So therefore, in this study also in 2020, it did found that a large number of patients who were fluoroquinolone resistant bacterial keratitis, they were sensitive to using fortified antibiotic. However, they had found that several patients, they have also reported that several patients were susceptible to the monotherapy in their past experience. So now looking at the scenario in India, if you see the susceptibility and resistance, there is a general rising resistance of Pseudomonas to the currently largely used fluoroquinolones, catafloxacin and moxifloxacin. And similarly, there is a rising resistance to Staph aureus as well. This has been seen in different parts of the country. And this particular study is uh, from the LB Prasad group and a trend analysis of 8 years. Dr. Savitri Sharma needs no introduction. And a very nice, reliable data has shown that there is a very, very big, serious concern that we all need to be aware of. Similarly, data from Delhi, where I am and where I practice, here again, we have a study from Shroff Eye Institute, and here they have found similar what we expect, that there is an increasing resistance. And I'd like to highlight here that catafloxacin resistance, if you see, to Pseudomonas again is showing as an emerging problem, and similarly with moxifloxacin. So now what do we do about it? How do we understand, and how do we select it? So one is, as we see, we look at the current susceptibility pattern. The other thing is that we go by the actual objective values to know as a starting point. So typically we have been relying on minimum inhibitory concentration values, and as we want to go higher and higher, we can take the MIC 50 and the MIC 90. So that's one. But there are certain limitations of purely relying on MIC data, because this is effectively the potency in vitro. And there are many other factors which may come into play in the host tissue, as I will explain later on. Secondly, the MIC value may be high, but it is how effective and how quickly it eliminates the organism. That is something which is not defined by this data. And that is something which we need to look at, because the longer you allow the antibiotic to be available at a lower value, and you have those highly powerful bugs who are, survival of the fittest ones, and they may then have more time to get exposed to the antibiotic and develop the mechanisms to have resistance and then proliferate in the absence of any other competition. So what else can we do? We would look at the agent, obviously. We would see the one which we expect to be the most susceptible. Then we'd look at the route. As I said, if something is, you feel the topical drops are not going to reach, then you will have to give it directly by intracameral or intravitreal injection for endophthalmitis and so on. And then the other thing is that you can also try to increase the concentration or the dose, the amount of drug that you're delivering. So one is the concentration and the other is the frequency. So this is the other thing that we have in our hands. So there's basically a tripartite relationship. You have the antimicrobial drug, which is going to work on the bacteria. And if the mechanism or the relationship between the organism and the way it's killed by the antimicrobial agent is the pharmacodynamics. There's the bacteria which are interplaying with the host. There's the infection, and the host will try to counteract by its own defense mechanism. And the antimicrobial agents interplay with the host. The host will be using its pharmacokinetics, the tear flow, and the way that the antibiotic is removed from the body. And the antimicrobial will affect the host by toxicity. So this is the tripartite relationship, which is very dynamic. And it will change from person to person and from organism to organism and agent to agent. Now, looking at the pharmacokinetics and pharmacodynamics, the principle to determine the antibacterial efficacy, we have to understand that as far as pharmacokinetics are concerned, we are worried about how much time or how well or effectively the antibiotic is available at the site of action. So as you can see, it will determine upon how the maximum concentration is reached, how long the maximum how much time it takes to achieve the maximum concentration as Tmax, and how long it's going to remain as shown by the half-life and the area under the curve. And the pharmacodynamics is the effect of the antibiotic on the organism. This will depend upon the biological and therapeutic effect. It should have a broad spectrum, so it kills all the organisms, and it should have a low potency to develop resistance. So there's a low mutation supportive action. And then we can look at the MIC 90 rather than the MIC 50, and we can also look at the mutation prevention concentration. So these are a lot of further values values to take into consideration. But this is important to understand and in selecting the antibiotic more objectively and scientifically. So now just to show you the similar concept by means of a graph. So you have an antibiotic which has been provided, it's been delivered, and you want to make sure that the amount or the strength of the antibiotic available at the site of action is more than the minimum inhibitory concentration. Secondly, it has been confirmed that if you have a better concentration, a higher concentration, there's a higher rate of killing, and we want to kill the organisms fast. So we want to have a quick rise to the peak. We want that high concentration to be maintained for a longer time. So we like to see the time for which the strength is more than the minimum inhibitory concentration. We want to look at the area under the curve for which the concentration is available higher than the MIC, that is the effective concentration. And so we can also look at the AUC-MIC ratio, maximizing the amount of the drug received and making sure that its duration of action and availability is prolonged adequately. Here again, as you can see, that the tendency for gram-negative organisms to be resistant or be less susceptible to the fluoroquinolones is a concern, because this ratio is more than 125 for gram-negative organisms and more than 30 for gram-positive organisms. So if your smear shows that it is a gram-positive organism, and if it's a gram-negative organism, and you decide to start with a fourth generation fluoroquinolone, you should not assume that this is going to be absolutely fine. You have to reassess after 48 hours, check your culture report and check the clinical response, and then proceed to decide what to do further. So this is the principle. You want to maximize the concentration to get the maximal therapeutic efficacy. An enhanced area under the curve to the MIC ratio will tell you the therapeutic efficacy of the antibiotic. And an enhanced concentration versus MIC ratio is going to determine the suppression of acquisition of resistance. And this is what we want in our ideal antibiotic. So just to make it more simple, you would like to maximize the antibiotic concentration. And as I mentioned earlier, apart from the agent and the method of the administration, we do have a handle on the dose. The dose could be just given every half hourly or 1 hourly, or also we could increase the concentration, that is the amount per drop. So you will maximize the tissue concentration, maximize the therapeutic efficacy, and by killing as many organisms as possible, preferably all, you will minimize the emergence of resistance strains. So when you come to this concept of maximizing antibiotic concentration, apart from the fortified antibiotics, which is a concept which has been there for decades, that you do not use the normal concentration, you will use fortified antibiotics. But for commercially available, the two agents where this strategy has been used is with gatifloxacin and levofloxacin. So this is something which is another attempt to provide something from a commercial perspective or a readily available perspective, rather than relying on the ophthalmologist to start, compiling and making up the antibiotic on their own. So certainly we would prefer to have a ready-made drug which you can use effectively. But until we get that product, we have to keep the balance, whether to use the fortified versus the commercially available. So summary, I would say that drug resistance is an inevitable consequence of irrational antibiotic use. And though we may say that it is terrible, etc., it is something that we have to stay with. It's no way that ophthalmologists are going to be able to change the entire community. There are so many people are involved, so many different disciplines, and the general public also. So we have to accept that there is going to be widespread use of antibiotics, no matter what we say, no matter how much the media screams about it. But drug resistance is, there is going to be irrational antibiotic, and drug resistance is an inevitable consequence. It is better we go for a smart solution to get rid of the organism and minimize drug resistance by the weapons in our hand. So therefore, as I said, you take it for granted that bacterial resistance to fluoroquinolones is there and it's going to get worse. We have to have broad spectrum coverage and make sure we use the best agent most effectively, use the more potent antibiotic formulations with the lower propensity for development of emerging resistance. We can look more at the pharmacokinetic and pharmacodynamic theory supplements with topical antibiotics, as you correctly know. If you have a corneal ulcer which is not responding, we even do an intrastromal injection. That's one example. And the efficacy of fluoroquinolones improves with higher concentration and better tissue availability. This is also for sure. So with this background, I would like to say that one has to have a judicious combination of academic knowledge, practical experience, and the information available by established studies to decide which antibiotic to choose. And we look forward to the rest of the lectures, because that is going to give you a more practical and also a better